Everyone loves math, right? Okay. All right. So test 2 review. What did we cover? We had neurology, right? What else do we have? We had rheumatology. Pediatrics. Yep. All right. Those are the big 3, right? Okay. What else? What questions do you guys have? You're like, I haven't even looked at the material yet. That's okay. Triage. That's what school is all about. I understand. Yeah, it's important to have that kind of realization that you're not the most important class to your students unless the test is the next day. Anywho, though. But my test is Monday, so you guys will care about it over the weekend, so I'm sure we'll get lots and lots of emails. Anywho, so just a couple of slides just to kind of generate some conversations. I'll just kind of, you guys know the reviews here. So anyway, anti-epileptics, good things to know, right? We talked a lot about mechanisms of action. So for instance, if I were to say something like phenobarbital, how does that drug work? You would instinctively say, I know it's a barbiturate, right? You would know that by Monday. And then you would say, oh, it probably makes GABA work better, right? It helps the GABA channels open up more and allow chloride to flow in, and that would stop a seizure, right? Yep, you would know that. And then also things like phenytoin, how does that work? Anyone? Like sodium channel blockers, things like that. So mechanisms of action are good to know. Also, like the adverse effects that are associated with them. So like if things are causing a hepatotoxicity, know what to, if that's a common thing, for like valproic acid or something.
That was a question actually I had.
Sure.
Is it the majority of them that cause hepatotoxicity?
Not the majority. Certainly things like phenytoin, you can see it. Like valproic acid is probably one of the bigger ones that I see at least a little bit more commonly. At least you see rises in the LFTs, maybe not like full-on like fulminant hepatic failure. That would obviously be bad, but certainly you can see some rises in your LFTs with that one. But yeah, so again, if they're being metabolized to the liver, then that increases your chances of that happening. But that's a reason why I see a lot of people go towards Keppra nowadays. Usually don't see as many like adverse effects from Keppra, so they end up kind of going with that one. It's a lot better tolerated than some of the older agents that we have.
Okay, so being metabolized to the liver doesn't necessarily mean that.
Not necessarily, right? So if I mentioned it specifically, then yes, right? But also keep your drug interactions in mind, right? So we talked about a lot of them that either inhibit the CYP system, so specifically like inhibiting CYP3A4. We'll have some that will induce 3A4. There's quite a few that induce metabolism, so be aware of that. So for instance, if I were to have a drug that is metabolized through CYP3A4 and then I put on an inducer, what would I need to do to that other drug in order to keep the same blood levels? I need to increase it, right? So you can think about things like that and how you'd have to adjust your drug doses in order to overcome those kind of interactions, right? So obviously CYP3A4 being a big one, but you see other ones being affected, 2C9. That can be really important for warfarin. So you can make warfarin work less effectively potentially if you have like a CYP2C9 inducer on board, things like that. Also remember the significant drug interactions between things like valproic acid and like lamotrigine. Like valproic acid will inhibit metabolism of lamotrigine very significantly. You almost have to like half your dose basically whenever you add those two on board. That can be an important one because like with something like lamotrigine, you really worry about things like skin manifestations, right? So you can see Stevens-Johnson syndrome, have a lot of rashes, blisters, things like that can develop. So big things to worry about. I'm not going to make you guys know the normal ranges for medications, but there will be questions on there where you have to interpret drug levels and see what to do with them, right? So say, for instance, I have a patient who came in and their valproic acid level was 75. The normal range, say, being anywhere between 50 to 100 mics per ml, okay? And then they're coming in and they are ataxic, they are having nystagmus, they are, falling asleep in school. What would you do with that patient? You decrease it? Quite possibly. All right, so because again, even though the patient's in the therapeutic range, doesn't necessarily mean that that's therapeutic for that patient, right? So it could be a thing where you may decrease the dose. Actually, with valproic acid, there's kind of a unique thing where I've had a patient like that where they were assuming the patient was, as a high school student, they assumed that he was either drunk at school or something, as he's basically falling asleep and slurring his words. And so what actually happens with valproic acid, you can have a depletion of carnitine, levocarnitine specifically, and you can actually have a hyperamonemia that develops from that. So that's kind of a unique kind of thing where even though his valproic acid level was like, in the normal range is probably 70 or something, his ammonia level came back like 70, almost probably 100, which is elevated for him. And so it's actually a thing where he gave levocarnitine actually helps to deplete that. So it's kind of a unique thing. That won't be on the test, but it's kind of a unique aside because you look pretty smart if you can be like, oh, I think he's toxic from this, and you get the level, because no one ever checks an ammonia for the most part unless they have history of hepatic disease or something. Sure enough, it was elevated, so you feel kind of like a hot shot for doing that. And then if there's any like specific drugs for certain seizure types, like probably know that, right? A lot of them are going to be kind of can fill the role of treating multiple types of seizures, but if there's any specific ones that treat any specific types of seizures, probably a good thing to know for the test, right? Interesting clinical practice, also good things to know. Okay, let's say I had a patient who's coming into the emergency department and they were in status epilepticus. How would you treat that patient? You get some lorazepam? What should you do before that? Airway, yeah, ABCs, right? Always do your ABCs first. Once you establish their airway, then you mentioned giving lorazepam, which is what type of drug? Benzodiazepine. How does that work? GABA, yeah, it increases it helps the GABA to work better, right? Because it binds to those benzodiazepine sites, helps for GABA to bind more readily, so it opens up those channels and get more chloride in flow. Okay, so I give some lorazepam. The guy also got like rectal diazepam on the outside, still seizing. What do you do then? Yeah, so phenitone's usually a pretty good option. I see a lot of people using that. I see more neurologists nowadays starting to use IV Keppra, being a popular one. Also consider what the patient was on beforehand, right? So for instance, if it was, we have this probably more often than you would think, but we have a lot of like difficult to control seizure kids who are coming to Florida for as part of like a Make-A-Wish trip or something. And so sure enough, they get stressed out. They're at Disney. It's super hot. They forget their medicine at the home or something like that. So of course they come in seizing to us, right? So, you have to figure out what were they on previously, what are their drug levels for those things. So, for instance, if they come in seizing, they hadn't had their Keppra for that morning, then you probably want to go ahead and give them the Keppra, right? So you can go and rebolus with that one. Or, see everyone looking at the bug flying around. Or, phenytoin, if you need to rebolus with that, you can do that, right? What's the big risk with giving phenytoin IV? That's okay. If anyone can get the book.
I'm worried about extravasation.
Okay, so we mentioned phenytoin given IV, the big risk? Extravasation, right. So that's why we use what drug instead?
Phosphenitone.
They use phosphenitone instead because it's a lot easier on the veins, it's a lot more water soluble. If you look at like phenytoin, the pH is like 11, like it's very, very tough on the veins. So that's very, frequently why we have issues giving that to children, because oftentimes they have very small, delicate veins if you can even get an IV in the first place. And so that's why we try to veer more towards like phosphenitone if that's available, or do like Keppra. Obviously you have to worry about shortages and things like that. Okay, so we gave kind of multiple rounds of benzodiazepines. Patient's still seizing. We gave phosphenitone bolus. They're still seizing. What do you do then? Yeah, usually you have to start kind of considering, okay, what else is going on here? Like, what is at play? So lots of things you have to kind of rule out or rule in based on what's going on. So obviously that patient is going to be, needing like a CT, see if there's any kind of intracranial processes going on. Lots of different things you're going to be doing. But yeah, then you have to consider like, okay, do I need to just put this kid into a coma at this point, or adult patient? Could be anyone. I just think kids naturally. Yeah, phenobarb is a big one that you might use. Pentobarb is a good one for kind of just knocking them down completely into that kind of pentobarb coma, as I mentioned. But yeah, so you might run through multiple medications at that point. So it kind of opens up pretty broad. Some patients might get phenytoin, then they might get Keppra, and they're still seizing. Then at that point, you may say even something like propofol. You guys heard of that drug before, right? Who famously died from that? Yeah, Michael Jackson succumbed to propofol. So it's a very common one we might use also has anti-epileptic features, but usually uses like more like a general anesthetic, right? So you see it used a lot in the surgery world. So that might be used as well. It just depends on the kind of situation.
What kind of time range do you think we're talking about from presentation with somebody from the ambulance with status epilepticus to the time that we actually say, okay, we need to just put this person down?
That's a really good question. It depends on the patient, because sometimes you may have, because again, the definition of status epilepticus is what? intractable seizures, but they don't
come back from it.
Yeah, they stay in that post-ictal state, and they kind of go between seizures. So they may not be seizing that entire time. So you may see cases where they'll kind of come in and out of it. And so you may say, okay, I gave them the benzos, and okay, that treated them. They're not seizing anymore, and then 10 minutes later they start seizing again, right? So it could be kind of more protracted depending on the situation. But say for instance, patient comes in via EMS. Hopefully they have an IV already placed, right? You can give them a couple rounds of Ativan probably over the next, say, 3 to 5 minutes, right? So probably 1 or 2 doses there. Kind of getting an idea from EMS what they already received. Chances are they probably got some Versed en route. So you kind of figure out, usually figure out like 3 doses of benzos and they're still seizing. Like at that point, you're considering, okay, we need to do something else, right? So at that point, you start to get, things like phenytoin on board. You get things like Keppra, depending on like the kind of situation, the kind of place that you're practicing. It could be like, maybe your nurses are drawing up the meds down in the emergency department. Maybe pharmacy has to make it up. So like for our institution, pharmacy makes everything that needs to be reconstituted. So we, if that kind of patient comes in and like, the first dose are not really responding to, I'm already calling up and say, hey, go ahead and get a load of phenytoin. Here's how much the patient weighs. The order will come in later. Go ahead and get that made and sent down to us, right? So by that point, you're probably talking like, maybe 10, 15 minutes or so, kind of during that whole time frame where you're trying to figure out what's going on. At that point, like you're also like, okay, we probably need to intubate this patient, which you're also, when you intubate a patient, 2 of the big drugs you give are going to be an induction agent, which may have some anti-epileptic properties, so you can use something like propofol to kind of knock them out completely. And then also, do you guys know the other drug you give? Paralytic, right? So what's the problem with giving a paralytic to a seizing patient? Yeah, so their brains are still getting fried, but you can't see them seizing anymore, right? So we call that a non-convulsive status epilepticus. So you also have to consider using like a short-acting paralytic, because you want to be able to do that neuro exam to kind of figure out what's going on with them. Or have like a bedside EEG that can kind of tell you. I had a really bad theophylline case one time where it was a little old lady, she's probably like 9,000 years old, and in the nursing home on theophylline for her COPD. No one ever checked her levels. Her renal function was steadily decreasing. They never adjusted her dose, and then she got dehydrated, so she comes in seizing from theophylline. And that unfortunately was a case where the CNS load of theophylline was so high at that point that even though we had given her every drug under the sun, she was still in this non-convulsive status, and there's no good way to pull that drug out of the CNS. So she unfortunately did not make it through that one. But yeah, so depending on the cause, you're also looking at, okay, what else could be causing the seizure? Is it, medication based? Is it, hypoglycemia? That's easy to treat. Is this, intracranial process is happening? Could be lots of things. So, good. Yeah, so that's kind of the general management for status epilepticus. But remember, ABC is always first, and then you kind of worry about the rest of the stuff. If I couldn't get an IV placed on a seizing child, because imagine they're kind of shaking around, it could be difficult to get IV placement. What other route could I give? Yeah, intraosseous is usually the next thing we're going to do. That's why a lot of cases you may see intranasal Versed being used as well. So they might be using that in the EMS route if they don't have IV placement yet. So you can sometimes see that. That's where the rectal diazepam can be useful if you don't have IV access. We're seeing a lot of the neurologists starting to give out or give prescriptions for IV forms of Versed so that the patients can use that intranasally, because this will be easier to do than giving the rectal route. So anyway, so any questions on that? All right. Next on Parkinson's, good to differentiate kind of how your drugs are working. So obviously going back to the mechanism, knowing which ones are neuroprotective, so things that are going to help keep those dopaminergic neurons good for longer, is going to be useful, and also know how to treat specific symptoms. So say for instance, I had a kind of a new diagnosis Parkinson's patient. What type of drugs could hopefully prevent those dopamine neurons from crapping out sooner? So I can try to keep those dopamine neurons kind of firing for longer. Yeah, MAOB inhibitors are good for that. Anything else? Yeah, dopamine agonists, absolutely. So someone reviewed their slides. Awesome. Yeah, so you can give it MAOB because, again, that helps to prevent that breakdown of dopamine so it sticks around for longer, or dopamine agonist itself. Because you guys remember that the excitotoxicity that happens there is from the degradation of dopamine. So as you keep cleaving dopamine, you're forming those free radicals, those reactive oxygen molecules that can go in and start to cause protein denaturation and cellular death. So we're trying to stave that off as long as we can for those early patients, so that way we don't eventually end up on what drug? L-DOPA, right? Because that's eventually everyone's going to end up going to be on that therapy, right? If they were just having tremors associated with kind of early Parkinson's, what would you treat with that? Treat that with? So think back to your medicines for schizophrenia. Remember when we cause like an acute dystonic reaction from blocking dopamine receptors, what drug do we give? Yeah, Benadryl. Yeah, you give Benadryl. You give an anticholinergic, right? Because remember that anytime you're blocking dopamine, it's kind of on a seesaw where you're blocking dopamine activity, you have more acetylcholine activity and vice versa. So if they were having issues where they weren't really having a lot of hypokinesia associated with Parkinson's, but they were having kind of tremors at rest, that would be a good one where you'd want to use an anticholinergic, right? You have to be careful with anticholinergics in older patients because that can worsen dementia and their mental status, so you have to be careful for some of that stuff, right? Also be aware of kind of how to get around some of the kind of the kinetic issues with giving L-DOPA. So for instance, if they're having issues where they're having, because you guys remember that graph where you're kind of shooting for that sweet spot where you're having kind of relief of their hypokinetic symptoms, but you're not having those dystonias from getting your levels too high. And that kind of that range will narrow as time goes on. How can you keep patients in that range for longer? So whether it be using like a extended release format to where you don't really have as big of a peak, but it has kind of a more kind of plateau kind of look to it. Whether it be changing around their dietary restrictions. So for instance, if I wanted to have better absorption of L-DOPA, how could I do that as far as diet goes? Remember, they're competing for amino acid transporters in the gut. Yeah, you spread out the protein, right? So you make sure that they're not having a lot of protein at the same time they're taking their L-DOPA. So things like that, little tricks that you can do to make sure they're absorbing the drug well and they're not really getting those kind of dystonic peak symptoms that you saw there, right? Okay, any questions on that? Okie dokie. So then Alzheimer's, again, not a ton of drugs there. Do you guys remember any major drugs we used to treat Alzheimer's? Aricept or donepezil. Do you know how that drug works? So it's an acetylcholinesterase inhibitor, remember, so we're worried about losing those cholinergic neurons in patients with Alzheimer's, so by using an acetylcholinesterase inhibitor, you have more levels of acetylcholine around, so you can have improved memory and cognition with those drugs. There's also the NMDA receptor antagonist, amantadine you can use for that as well, so keep that in mind that there's a couple different options there, but not a ton of drugs for Alzheimer's, unfortunately. Any questions on that? I talked about MS. Again, if you were to have a patient who's coming in for kind of an acute, kind of pain exacerbation episode for their MS, what kind of drugs would you want to give off the bat? Yeah, so steroids are always going to be good for acute exacerbations for MS, right? Because it helps to decrease all of that inflammation and the edema around kind of the neurons and things that are getting attacked for those patients. So again, for acute exacerbations, the therapy is different because you don't want patients on long-term chronic steroids due to side effects. So then we also have the disease-modifying therapy. So those are going to be things that kind of slow that progression. You guys remember any drugs that do that?
IVIG?
There might be a case for using IVIG. I've not seen it used very frequently, but honestly, I don't see a lot of MS patients. Usually get diagnosed a little later on in life. Interferon, though, you may use, right? So interferon could be one of those things that helps to decrease or as a disease-modifying drug. But there's also some of the newer oral agents. So this is one of those cases where the advent of new oral therapy is really kind of changing the face of how we treat MS. So things like fingolimod and other drugs like that, they can all be immunosuppressive, but are able to take orally. So again, no side effects for some of those drugs, especially things like interferon, really bad kind of neuropsychiatric effects you can see there, like patients have worsening depression, suicide risk. Interferon is just a really bad drug in general, but for a while it's kind of all we had to treat for some of those patients. And also, if they have other symptom issues, so if they're incontinent, like what type of drugs can you give to help deal with that? So you might use like an anticholinergic specifically for the bladder. So things like ditropan or oxybutynin might be a good option for that. Or if they're having, muscle spasticity issues, do you guys know any drugs you could use for that? Yeah, muscle relaxants such as? Baclofin's a good one. What did you say? Yeah, Robaxin or methocarbamol might be a good one. Loxaril, yeah, cyclobenzaprine. I don't see, that's more of an anti-epileptic. Sometimes you'll see for some of those kind of other, some of those like neuropathies and things like that, you may see some anti-epileptics being used, as like carbamazepine I mentioned, I think, phenytoin potentially. So certainly you might see vigabatrin being used in that situation. What if I was having muscle spasticity that wasn't being relieved by those skeletal muscle relaxants? Is there anything I can use to paralyze the muscle? Yeah, Botox. You can make a case of botulism, right? Yeah, so Botox can be utilized to help deal with some of those kind of refractory muscle spasticity issues.
So is it like a single muscle twitch? Like
sometimes they can have like specific muscles, or like a large muscle that's having the spastic issue. You can just inject it directly into that. So like we have a lot of kids with cerebral palsy that have issues with spasticity, at least on the pediatric side. And so we have our one doc. What's her specialty? It's like she specializes kind of in more like rehabilitative medicine. So she works a lot with those kids, but she'll do Botox injections for some of the larger muscles to help kind of decrease a lot of that spasticity. So the arms, the legs, and things like that.
Can you still use that limb after?
Yeah, because the Botox isn't permanent, so it'll eventually kind of degrade on its own. But you may have kind of limited use of it, right? So you don't want to paralyze the entire muscle, but maybe just have less spasticity associated with it. Remember, we can do the same thing for what other condition we talked about?
Migraines.
Yeah, migraines. So sometimes you can do, if they have especially like really bad tension, headaches, associated with some of the neck muscles, you can use it there as well, right? Good. We talk about headache disorders. What are some major drugs we can use to treat headaches? Yep, so our triptans, right? How do the triptans work? Something to do with serotonin, absolutely. Yes, it's 5-HT1B and 1D agonist, right? And those are going to do what to the cerebral blood vessels? Constrict, right? So we want to have constriction because normally have dilation there. That's what's causing a lot of that pressure and edema on those nerves. Remember the drug-induced causes, because again, a lot of times if your patient's having migraines, it could be related back to the medicines they're on, right? A lot of the preventative meds that we can put patients on can also induce migraines. So things like propranolol or some of your calcium channel blockers. So keep those kind of things in mind. Look at drug interactions, especially between things like your ergots and your triptans. You don't want to mix those up in the same 24-hour period. You see too much vasoconstriction, right? Worry about that. Contraindications is also important. So if you had like a pregnant patient who came in who was complaining of migraines, what drugs do you not want to give them? You don't want to use ergots, right? You don't want to have too much vasoconstriction of those blood vessels in the fetus, and it's no good. Category X, don't use it. But the triptans may be used if you've kind of exhausted other issues. So, for a lot of pregnant patients, they kind of have to go through, Tylenol, which usually is going to work for a lot of migraines. And then when can I not use NSAIDs for pregnant patients? Yeah, third trimester, and it becomes a category D because you worry about closing the ductus arteriosus. Yes, absolutely. Fantastic. So again, look at your patient, kind of figure out what would be, if they have any contraindications, and then how that will guide your therapy to using one drug versus another. So you may have questions like that come up, say, you have such and such type female, patient presents to, your clinic for migraines, what drug is going to be best for her? And so based on contraindications, other drugs they may be on, you have to kind of select what might be the best option for them, right? You may have the option to just tell them to tough it out and walk it off, right? That could be a good, no, you don't want to do that. Give drugs to your patients. Okay, talk about rheumatology. Again, a lot of similar drugs may pop up between some of these different conditions, especially some of these like immunosuppressants and things may show up multiple times. Again, we can use them for different purposes here, mainly the DMARDs and things like that. So like your infliximabs and your rituximabs, things like that will end up showing up there. So again, know their mechanism, know if it works against TNF alpha versus interleukin 6 versus the CD20 receptor. Be able to differentiate between those. We're always an adverse reaction I worry about with the monoclonal antibodies. You worry about infection, absolutely. Anaphylaxis, yeah, because anytime you're injecting foreign protein, you worry about having allergic reaction risk. Good. Look out for the place in therapy. I don't know what that word is, but how would you treat a patient with osteoarthritis different than rheumatoid arthritis? Speak up louder. Yep, so okay, so there's no really disease-modifying therapy that we can use for osteoarthritis. That's a key point there, right? So you never use infliximab for someone's knee osteoarthritis. It wouldn't do anything for them. And then also you're going to rely more heavily on NSAIDs and things like that. Because again, if you're looking at the pathophysiology, again, it's more of a mechanical issue with osteoarthritis versus rheumatoid arthritis. More in the inflammatory system is really the key player there. So you certainly can use NSAIDs for osteoarthritis, but they try to hold off on those as long as you can. Use things like Tylenol if possible, versus they're going to absolutely have to be used in RA for the most part for that kind of symptom management. Which one can you use oral corticosteroids for? Yeah, RA is going to be used for kind of acute exacerbations, kind of similar to what we saw with like MS or something. What type of steroids can you use for osteoarthritis? Yeah, so intra-articular injections. And what's kind of the problem if you use that too often? Yeah, like tendon atrophy and things like that. So you can actually see further joint destruction if you use it too frequently. So usually maybe like 3-4 times a year is kind of the most often you can utilize that. All right, good. Any questions on that? Pretty straightforward, I think. I mentioned osteoporosis. So what are kind of the 2 drugs everyone should be on for prevention of osteoporosis? Before that.
Calcium and
Yep,
vitamin D.
calcium and vitamin D, absolutely. So anyone should be recommended to be put on that, especially if they are at risk for osteoporosis. And then if they have a history of a fracture, or if they are already osteoporotic, or they're really at high risk, then what do you put them on? Yeah, bisphosphonates, right? So remember things like how do you administer that drug, or who might not be a good candidate for oral bisphosphonates based on the fact that you have to stay upright for 30 minutes, or there's significant drug interactions because the bioavailability is so poor for those drugs. Maybe IV might be a better option for some of them. So kind of keep those type of things in mind. If I had a patient who had really poor, say, kidney dysfunction, what do you have to remember about vitamin D?
You have to give them the active form.
Yeah, you have to give them the active form, which is calcitriol. Yep, calcitriol is the active form of that, right? Some patients, if they have poor liver disease, but they have poor liver function, but their kidneys are okay, sometimes you can give them the kind of half-activated vitamin D, like calcifediol can sometimes be used, but routinely I see more patients just get put on calcitriol, already active form. Good. All right. And then we talked about hyperuricemia. So again, how can I treat an acute exacerbation of someone's gout? You can use some NSAIDs. You can use colchicine. How's colchicine work? It's an antimitotic drug. It helps to block that spindle formation. So again, it can have pretty significant side effects, right? So that's why we don't like colchicine as much, because you worry a lot about nausea, vomiting. A lot of those rapidly dividing cells can take a hit. So you see GI issues. You can have some depression of the immune system, things like that that can occur. So any other drugs I can use? So allopurinol, does that treat an acute exacerbation? Yeah. What other drugs can I use? So NSAIDs, you had colchicine. Still not working. They're still in a lot of pain. So my toe hurts so bad. What are you gonna do? Drain it? Yep. Maybe you can do some drainage. How medwise? Yeah, possibly steroids might be useful. But also consider things like opioids, right? You can potentially use that if things like NSAIDs and colchicine are not working. So keep all those kind of options in your mind. As far as like what your arsenal is of things to use to treat some of these acute exacerbations. And you mentioned allopurinol, which is a form of urate lowering therapy. Do you guys remember how that drug works? You pee it out. Basically prevents the production of the uric acid, right? Because it helps to block that xanthine oxidase enzyme, right? So basically pee out the precursors instead of actually producing the uric acid. What other drugs can you use for this purpose? There's that febuxostat, which is also a xanthine oxidase inhibitor. It's a Uloric, I believe is the brand name. And then there's also another drug that blocks the reabsorption in the kidneys. Do you remember that drug? It's probenecid. Probably doesn't get used as much, but certainly allopurinol can be used. Remember we had that one drug that we can use for like tumor lysis syndrome, that resburicase, that can directly just cleave the uric acid and turn it into a more water-soluble form that the patient can just pee out then. Right. Okay. And then we mentioned peds. So again, keep in mind that pediatric patients are just tiny adults, right? So you can treat them all the same. No, you don't do that, right? Big changes in their kinetics. So again, keep in mind things like, what's their vomit distribution for hydrophilic meds for like an infant? Remember, they're big bags of water. Should be higher, right? So they have a larger volume of space for that drug to partition into. That's why I have to give like larger dose on a mg per kilo basis for peds patients for like gentamicin or something versus an adult patient, right? Interestingly enough, my sister just had her 2 twins last night. Thank you. I'm now triple uncle. Interestingly enough, her first daughter, because I mentioned her previously, how she actually ended up on the progesterone shots, because her first child came at like 32 weeks and like 6 days or something. Interestingly enough, her water broke exactly at 32 weeks and 6 days this time as well. So she ended up coming in, getting admitted. They put her on intrapartum antibiotics. Interestingly enough, they put her on vancomycin. I'm not sure if I don't remember her ever having penicillin allergy, but keep in mind that that helps to prevent spread of things like group B strep over to the infants. She also got put on steroids. You guys know why they put her on steroids? Yeah, it helps to develop like surfactant production in the infant. So they end up getting born. I'm not sure if there's any. I just saw some pictures, but I'm not sure how they're doing otherwise. But they'll probably be in the NICU for a little while until they can make sure there's no infection or anything, and then kind of send them on their way home. So. Huh?
How big are they?
I don't know. I didn't see a weight either, so I'm waiting for my sister to. I'm sure she's pretty tired, as I can imagine. But yeah, they actually look kind of big, so I'm not sure. Maybe the picture scale was kind of goofing it up. Yeah, we need to know the details. Yeah, as soon as I get details, I'll let you guys know. Yep. Okay, so then we talked about the drug dosing calculations. I have a few examples there, just so things we can kind of practice in a second. And then also like treatment for those neonatal conditions. So for instance, if they did have, say, some respiratory distress syndrome, what kind of drug could I give to them? Yeah, we give surfactant, right? So you give that via wet route. Endotracheal, right? So you can put an endotracheal tube down and apply that to help kind of provide some exogenous surfactant. Okay, so any questions on that? Remember CF, we talked about that a lot. So some of the kind of unique drugs used for CF, like that lumicaftor, ivacaftor, something like ursodeoxycholic acid or that ursodiol, right? So you can use that for what kind of complication? And the bear gallbladder juice for, yeah, to help replace their gallbladder issues, right? So again, they're not going to be able to not dispense, but they're not going to be able to secrete a lot of their own bile acids and things like that. So it kind of helps to deal with a lot of the fats and stuff they're ingesting, right? Okay. You mentioned that. Antibiotic selection. Also remember that you're covering for what types of bugs in CF patients. What are you really worried about? Pseudomonas is a big one, right? So, and then they oftentimes will convert over to that mucoid form of Pseudomonas, which is even more difficult to treat. So again, you have to shoot for high levels of antibiotics. You are oftentimes, and again, they metabolize drugs very, very quickly for the most part. So again, we're having to give more frequent dosing, higher doses in order to help manage those patients. And remember, we talked about how to give them their respiratory treatments, right? Remember how they have the chest physiotherapy they're doing along with things like mucolytics, along with antibiotics and things like that, and how you want to organize those to make sure they get the most bang for their buck, right? And then GERD and constipation, so we talked about all the drugs. Again, very similar therapy choices for adult patients, but just kind of review that if you need to. Okay, so we got some dosing questions. Let's say we have a 22-pound patient being treated with sulfamethoxazole and trimethoprim for a UTI. The dose is going to be 8 milligrams per kilogram per day of trimethoprim divided BID. Suspension comes as a 200 milligrams of sulfamethoxazole and 40 milligrams of trimethoprim per 5 mLs. How many mLs should the patient receive per dose? Okay, so first step, convert the patient's weight. Okay, so we get from pounds over to kilograms. How do you do that? Oh, isn't that weird? The patient's 22 pounds, huh? So he would be 10 kilograms, right? Okay, so now we have our conversion. Now we know how much the patient weighs. So 10 kilograms. And that way you're going to be figuring out next, you want to know per dose, right? So you can go ahead and divide that out. So how much trimethoprim per kilo per dose should they be receiving? 4, right? Absolutely, right? So you're going to do 4 times 10. So 4 times 10 would be 40. And so how many mL should they get per dose? 5 mLs, right? How many teaspoons is that? Yeah, don't use teaspoons anyway. It would be 1 teaspoon, right? It's 5 mLs. Yep, so don't do that because again, who knows what kind of spoons they're using? Who knows if they're going to be measuring it correctly? So, so that's a pretty straightforward one. Again, you can do most of the math with a scratch paper. You shouldn't need a calculator for the calculations on test, so just be aware of that. Okay, and then we're very similar to kind of questions like this. So again, keep in mind, read the questions carefully because I'll do things like that where I'll put, they're receiving this many mg per kilo per day, but I'm asking you the per dose volume, right? Or I'll put it in, per dose, and then ask you how much are they receiving in a day. Questions like that. So be able to read through this carefully and make sure you're answering the right question.
What was the ending for that again? What did you say?
I'm sorry?
The ending, like, answer.
Oh, it's going to be 5 mLs for that patient, right? So again, I just did, I know them getting 4 milligrams per kilogram of trimethoprim per dose. So I did 4 times 10 kilograms. So you get 40 milligrams, and then it's pretty easy there just because it's 5 mLs for that one, because it's 40 milligrams per 5 mLs. And again, keep in mind, you may need to divide that out to figure out how many, that always kind of annoys me with a lot of those bottles, is they always express their concentrations in per 5 mLs. I don't really care about that. I want to know how much is actually in there per ml. Also keep in mind what you're doing the dosing based on which component. So Bactrim is a very common one. You see kind of comes a combination, but you may see that with like amoxicillin with clavulanic acid. They'll express both, what the clavulanic acid concentration is and the amoxicillin. Make sure you're dosing based off of the amoxicillin component. Yeah, right. Okay. Let's say we had a 43 kilogram patient who is presenting secondary to a trauma. They got in a car wreck and they have hypovolemic shock. We need to give them some fluids, right? So you want to give them fluid bolus of NS, and then we're going to start the patient on a continuous infusion at 2 times maintenance rate. Okay. How much NS should the patient receive? So for their bolus, how much should they get? What's the dose? I don't usually ask you guys to know doses, but this is a good one to know. Just say, give them a liter and walk away. You're done, right? No, you don't want to do that. You want exact volumes for pediatric patients. So 20 mLs per kilogram is the fluid bolus. Okay, so do 20 mLs per kilo times 43, and what does that equal out to be?
86.
Add one more zero. 860. Yeah, if I gave a 43 kilo patient 86 mLs, they'd be like, what is this, like? Is it a dose for ants? Like, no. My mean game is strong. Okay, so anyway, so 860 mLs as a bolus of NS, right? Why do we use normal saline? It's isotonic, right? So we don't want to give hypotonic fluids or hypertonic fluids. We want to give that volume and keep it right there in the intravascular space. That's why we use normal saline, 0.9% NaCl, right? And then you want to start a maintenance rate. So what would be their normal maintenance rate for a 43 kilo patient? What's the rule we use? 421, right? So it means that they get 4 mLs per kilo per hour for the first 10, right? And then they get 2 mLs per kilo per hour for the next 10, and then 1 ml per kilo per hour for every kilo after that. So for a 43 kilo patient, you get 83, right? So you do 40 plus 20, so then you get 60, and then you have another extra 23 mLs you add on top of that, right? So practice that a few times so that way you can do it on test day, right? It gets to be second nature if you work with these patients very frequently. You'll be able to do it in your head, no problem. Good, and so then we said 2 times maintenance rate because we want to make sure he's getting lots of fluids. So then you just multiply that by 2, right, to get your correct answer. Everyone with me? So that's a very common thing where you may see like, patients start off on, 1.5 times maintenance, 2 times maintenance, usually until you kind of get them fluid repleted, and then you would, knock it back down to their normal maintenance rates. That's a pretty common thing you may see out there. What if you had an 18 kilogram patient? What would be their fluid bolus? So 18 times 20, should get 360 mLs for their bolus. So again, keep in mind, like if I were to hang a liter bag on that patient and just walk away and not actually program an actual amount to be infused, you can see how you can run into problems, right? So imagine doing that for like an infant who's only, or like a really preterm infant who's only, a couple kilograms. You can really run into some problems. So pulmonary edema can develop. It can be really bad for this patient. So be careful with that. And then what would be their maintenance fluid rate? So they get 4 mLs per kilo per hour for the first 10, so that's 40 mLs per hour, and then 8 times 2, which is 16. So so the total amount would be 56 mLs per hour would be their maintenance fluid rate, right? Well, if you want to do 2 times, then you do 112.
When you say bolus, what time frame are you looking at? Are you not squeezing this into your patient?
That's a good question. So it depends, because a lot of times your infusion pumps, the fastest rate that they'll go is 999 mLs per hour.
That's a liter?
So they basically get 1 liter in an hour. So if you have a trauma patient who's in hypovolemic shock, is that appropriate? No, you need to fill them up sooner than that, right? So depending on the situation, you may give that over an hour. You may divide it up and run it in 2 pumps going at 999, so that way it goes in over half an hour. For the smaller volumes, so like for 18 kilo kid, like you can probably program that in to run in pretty quickly. Ideally, these kind of boluses would be run in as fast as possible, especially with the trauma type patient. So they actually have rapid infusers, so you can actually infuse whole bags of saline like very within seconds, right? Basically, they have a really large bore IV tubing that's hooked up to the patient, and they have a pressure system, basically just squeeze out all the fluid out of the bag and into the patient. So you may see that. For a lot of pediatric patients who are coming in for resuscitations, the nurses will just have a bag of saline, draw it up in a big 60 cc syringe, and just do a push-pull kind of method. So they'll pull out, push into the patient, pull out again, push into the patient to get their volume. So they may do that sometimes as a more manual method to get the fluids in quickly. So lots of options there for that kind of patient. That might be a type of patient you do an IO in, especially a trauma patient that may have lots of issues where an IO would be appropriate for them to get IV access. Okay. Let's say we have a 6-kilo infant who is requiring some Zantac for his GERD symptoms. The dose is going to be 4 milligrams per kilogram per dose. He's getting that twice a day, and the solution comes as 75 milligrams per 5 mLs. How many mLs should this patient receive per dose? So what are my steps here? So I'm going to do 6 times 4, right? So you're going to keep in, see how this is different than what we saw with the trimethoprim sulfamethoxazole question. Here you have 4 mg per kilo per dose twice a day, not 8 mg per kilo per day, right? So be able to read that carefully so you can make sure you can discern the difference between those two. So say 6 times 4, which will be 24 milligrams that a child should be receiving twice a day, and then your concentration is going to be what? Divide that out. 75 divided by 5 is 15 ml. Yeah, so it's 15 milligrams per ml, the concentration. So then you just do 24 milligrams divided by 15, and you get your answer. I think it's like 1.6 mLs, if I recall correctly. Right, so be able to do is kind of, that one's probably a little bit more involved than I'd have you do on the actual test. It will be all round numbers for the test, right? But wow, it's amazing how all these answers round out to 10 mLs or 5 mLs or something really pretty straightforward. But that won't be real life, so be able to do things like this and for the real patients. Okay. Any other questions I can answer for you all? You have my email address. I'm sure you can seek me out if you need to. Actually, I have you guys are my only test on Monday. So yeah. So if you have any questions, please email me. I'll try to answer as long as possible. But Sunday night at 3 a.m. probably not a good time to get a response back. So just be aware of that. Okay. Otherwise, I will see you guys next time. Thank you. Thank you.